So, today we're going to talk about osteoarthritis and heart disease. You know what? I don't know if I'll ever learn it. Maybe I'm too arrogant. When patients say, "Oh yeah, I've got this," and when I say, "Oh no, that's not right," a few of them have said, I've got maybe some increased risk because I've got osteoarthritis. They were right. But again, it's still not like the inflammatory arthritis. So let's talk about it. Osteoarthritis and heart attack and stroke risk. OA, we'll call it OA, and cardiovascular disease, CVD. They're two of the most prevalent conditions affecting the US population and any aging population. Both are characterized by slow accumulation of disease or pathological change, eventually leading to adverse health outcomes. They share several risk factors, including age and obesity. What else has age and obesity? Well, diabetes, prediabetes. What is OA, osteoarthritis? It's the most common form of arthritis, for sure. It's a highly prevalent, it happens a lot, very common chronic disorder. One of the leading causes of disability among the elderly. As you see these pictures on the right here, we've shown a lady with what we call joint mice, swollen joints from osteo problems. And we'll show a picture of rheumatoid arthritis in a few minutes. Rheumatoid arthritis tends to hit these joints, the MP joints, the joints between the fingers and the hands. As you see with osteo hits the IP joints, the interphalangeals, these joints out here, the knuckles. That's a generalization, but again, that's what you usually see. One of the most common areas to see significant osteoarthritis you see on these two pictures on the right, in the knees. It is a big deal. Osteoarthritis occurs when the protective cartilage that cushions the ends of bones wears down over time. And it's associated with increasing age, female gender, obesity, injury at the joints, occupation. In other words, do you work with your hands? Do you work walking or running? Physical activity. Are you a runner, a jogger? Although OA is the most common rheumatic disease, I probably should have changed that to say arthritic disease, because people, when they think rheumatic, maybe they think rheumatoid. It's the most common arthritic disease. Very little is known about it, though, especially in terms of the relationship between OA, osteoarthritis, and cardiovascular disease. As I said, I was unaware of it. I had not thought it through. And yes, to credit on that position, it's a fairly subtle relationship. But once you start thinking about it, it makes sense. Physical inactivity. If you've got major joint knee problems, how are you going to get a lot of high intensity intervals, aerobics? You can. That's one of the things that we do, is help people problem solve in that area. And Janice is very good in that space. But again, it has an impact. Chronic inflammation. Again, this is the significant difference between OA, osteoarthritis, and rheumatoid arthritis, or psoriatic arthritis, the inflammatory arthritis. Osteo is not an inflammatory arthritis. It doesn't get nearly as much inflammation as the others, but there's still some inflammation. That's the point they're making here. It's referred to as a degenerative disease, but recent studies have shown there is synovium, or that padding, inflammation in that area. And that plays a role in the development of osteo. Muscle weakness. You remember, we've said multiple times, especially after we get to age 65 and beyond, one of our absolute biggest risk factors is loss of muscle mass. Well, guess what? If you can't move your knee very much and weight bear because of osteo in that knee, guess what that's going to do to the biggest muscles in your body? Your thigh muscles, your hamstrings, your quads, and your calves. So that is a very, very big deal. Non-steroidal anti-inflammatory drugs, NSAIDs, these are commonly used to treat OA, and NSAIDs are associated with increased risk of cardiovascular disease. So, OA and heart disease. So let's start taking a look at some of the studies. Here's one of them in BMJ, the British Medical Journal Open. The purpose was to determine the association between osteo and cardiovascular disease. It used data from the Canadian Community Health Survey, cycles 2000, 2001, 2002, all the way up to 2005. They identified 41,000 self-reported osteo sufferers. And they selected a one-to-one match for each of those sufferers, and they matched them by age, gender, and survey cycles. So what that does then, by the way, is that if you adjust for age, then all of a sudden it's been adjusted out, and it cannot be one of the reasons when you find a difference. If you find more osteo or more heart attack in the osteo group, and you've adjusted it for age, then it's not age that's causing that problem. So the primary outcome that they were looking at is self-reported heart disease. Secondary outcomes were heart attack, myocardial infarction, angina, heart failure, and stroke. So they did some sophisticated statistical activities. It's called multivariable log regression or logistic regression. Obviously not going to go down that bunny hole. But they estimated odds ratios and looked at sociodemographic status, obesity, physical activity, smoking status, fruit and vegetable consumption, medication use, diabetes, hypertension, and chronic obstructive lung disease. The results? Osteo is significantly associated with any heart disease, angina, and heart failure in both men and women after controlling for confounders like age. So the odds of heart disease were 45% higher in persons with osteo compared with the age match controls. Most associations appeared stronger in women than in men. And as you remember, osteo is more common in women than men. Anybody know the reason for that? I don't. I will say that joint injury is usually adjusted and protected by the muscles, by development of muscles around the joint. So greater musculature around joints may be one of the reasons why men tend to have less osteo. I certainly don't know the answer to that, whether that's the truth, and I don't think anybody else does either. But it's an interesting theory. I'd love to see some science around that space. Why women have a greater risk for osteo. Anyway, women have a greater risk for osteo associated with cardiovascular disease as well. Osteo was significantly associated with heart attack among women only. Now, other types of heart disease with men as well, but it was not associated with stroke. Now, what does that mean? Is that real? I don't know. To me, it sounds like just what we call a signal, a research signal, something you find once in one study, but you never know. I think that's why you always hear at the end of these studies, we need to have more research. So I'd like to talk with you a minute about the webinar. People don't understand what the webinar is. It's actually a great way to get some access to healthcare that you're just not going to get any other way. You actually get the lab tests yourself at a local lab, a Quest lab near you, for the inflammation panel and the OGTT and the insulin survey. These are things, inflammation and prediabetes, that your doctor just does not know about. And here's the thing, Harvard Health and many others have said, look, sudden death is not always so sudden. The Hollywood picture that it's a bolt out of the blue is not realistic. It's more like real lightning, preceded by clouds, wind, and rain. Stop that metabolic storm before the lightning strikes. And here's where that metabolic storm comes from. It's inflammation, and it has to do usually with prediabetes. So again, we actually get labs, we go over them in the webinar, and then you can start finding out how you can prevent that heart attack others said that you couldn't even predict. We can show you how. Thanks.